Hello, and welcome to another episode of Boundless Body Radio. I'm your host, Casey Ruff, and today we have another amazing guest to reintroduce to you now. Rick Olderman is a returning guest on our show. Be sure to check out his first appearance on episode 400 of Boundless Body Radio. Rick Olderman is a sports and orthopedic physical therapist with more than 25 years' experience. He specializes in helping people with chronic pain and helps his clients transition into a pain-free life. Rick is the author of several books and has written the popular Fixing You series of books, which are found on Amazon to help people with chronic pain or injuries. More recently, Rick has created downloadable video home programs to help people solve pain from head to toe. These programs include his pioneering approach to healing pain that has helped solve hundreds of cases of chronic pain at his clinic for the last 12 years. He has generally shared tons of free content, including sample chapters from his books on his website, where people can also pre-order his book and find his home programs as well as other complimentary content. He is also the former host of the Talk About Pain podcast. Rick is one of the top professionals in the United States when it comes to understanding recurring injuries and chronic musculoskeletal pain. He wants to enhance quality of life by helping people fix their pain once and for all. Rick Olderman, what an absolute honor it is to welcome you back to Boundless Body Radio.
I'm very excited to be here, and hopefully I can live up to that introduction.
Well, I'm thrilled to have you back. You know, we've been doing podcast releases every Monday, Wednesday, and Friday since October of 2020. So if you do that for a few years, you come up with a lot of episodes. And it's so much fun when I get to invite somebody back for a second episode, because I go back and listen to the original. That was an awesome episode. That was so helpful. I would recommend anybody go back and listen to that, as we went through all the different parts of the body and common pain and ways to address it. You were so well spoken, and I told you off air, that was a great one to watch because you were demonstrating everything, but also you're so good at describing things that I think anybody listening along could really listen to the episode and be helped with chronic pain. So yeah, thanks again for doing it. It was so fun to go back and listen to that one again. I'm really looking forward to this today.
Oh, well, I always have fun talking about this stuff, so thank you.
Yeah, I can tell. We love people who are passionate of whatever they're passionate about, which is great. You do have a new book coming out, which is fantastic. I definitely don't know that much about it. As we said in the introduction, it is available for pre-order. I know it's something off air that you said that you were very proud of. You said it took a lot of work on your end to put this together.
Yeah, so this book is called Pain Patterns, Why You're in Pain and How to Stop It. And basically, I also have a program that teaches other health and wellness practitioners how to do what I do. And in that program, there is a 10-page neurophysiology paper in there that's always just kind of, everyone's kind of, I ask a couple questions about it, but I don't really drill anyone about the neurophysiology of what I'm doing. And so I thought, you know what, I think I'm going to expand this. And I thought, I started working on it. I thought, yeah, maybe this will make a nice little booklet. And then, oh, well, okay, it'll be a little bit bigger booklet than I thought. And then suddenly it became this whole book. And I realized, oh my gosh, this is really this is what I believe that we're missing in medicine when it comes to chronic low back pain, sciatic pain, SI joint pain, which I believe are the three most misunderstood diagnoses out there, and the most confusing for practitioners as well as patients. So I really think this is the key to solving those, because it's been the key to me solving my patients' pain.
Wow. That's fantastic. It's interesting to kind of contemplate, people that are in chronic pain, where they jump into the system and what kind of help they get. You could go to a doctor, you could go to a surgeon, you could go to a physical therapist, you could go to a personal trainer, and just to think about the outcomes of all those different things. Like, you could have somebody that is going in for surgery or to fuse discs or something that is completely unnecessary had they found the right person with the right information. It's really interesting how different outcomes you can get in the industry,
Yeah, it is. And you bring up a really good point, Casey, is that each practitioner in our healthcare care system is a gatekeeper to their approach to solving pain. So there is no standard approach to solving back pain or sciatic pain or what have you. Each gatekeeper has learned their own approach to how they like to do it. Sometimes this is effective, sometimes it's not. I end up seeing all the people that it hasn't been effective for. And so the information in this book is what I believe most practitioners have been missing. And it's really a framing of the understanding of the architecture of our body. And one of the reasons this book was so difficult, Casey, was that I've tried to straddle the balance between providing medical professionals valuable information, but also make it usable for lay people to fix their pain. So from that standpoint, I've divided the book into two sections. The first section is more for those medical professionals that has a little bit more detailed information that maybe a regular person would want to know. But at the end of each of those chapters, I have 3 or 4 points that kind of wrap it up for them so that they're the take-home messages from the chapter. You don't need to know all the fancy detail stuff. So, and then the second section of the book is where there's testing and exercises to fix deeper problems that are causing the 3 pain patterns that I identify in the book as the source of most chronic and sciatic pain.
Wow. Wow. That's going to be so helpful. I love that. The good news is you're talking to an audience that when they hear chronic anything, I don't think they've got much trust in the medical system. Definitely, like if you just got hit by a car, I wouldn't come up to you and be like, yo, like, how's your diet? Did you eat your Wheaties this morning or whatever? Like we wouldn't, not recommend that people go to medical care if they need acute care. But when it comes to chronic care, I think a lot of people have kind of developed a bit of distrust around the medical system. So I think that's going to be very, very helpful. Before we dive more into the content of the book, though, we didn't really get much into this, your own like kind of personal story last time we talked. We talked a little bit about it, but not very much. Can you tell us, how you got interested in chronic pain to begin with, and how, last time we talked about how you kind of changed your mind about things. Can you talk about, like, as your career went, can you talk about how you adapted the way you were helping people, if you were maybe taught a system that wasn't as effective as you thought it might be to really help people get out of pain, or how that developed?
Sure. And to go back first, I don't blame people for not trusting the medical system, because once it's failed you once or twice or 5 times, why should you trust that system of approach? So these are the people that I would see. And so to answer your question, immediately out of physical therapy school, I went to work in a small rural clinic in southwestern Colorado. And literally at least half of my patients all suffered from chronic problems that no one had been able to solve. And I was one of 2 physical therapists out there. So if you went to one of us and he couldn't solve it, and then I couldn't solve it, well, you're kind of out of luck, So this traumatized me as a physical therapist, because I felt that my physical therapy education had trained me to deal with these types of problems. It had not. My physical therapy education had trained me more to deal with more acute problems. And there's a big difference between acute issues and chronic issues, which I kind of talk about in the book too. So anyway, this led me on the path to trying to figure out, oh my gosh, why is there so much chronic pain? And I just thought that I was a failure as a physical therapist, and that every other physical therapist knew exactly how to treat all of these patients. And because I was only working in this one little clinic in this one little corner of a state, I had no idea that everyone else was struggling with this too, until I moved to Denver. And that's when I worked for that, elite athletic club that we were talking about. And the first day I was there, my schedule was packed with all of these elite athletes, or non-elite athletes, just people with chronic problems that no one had been able to solve. And I'm just like, what's going on here? I'm in Denver, the heart of Colorado's, elite doctors, surgeons, physical therapists, chiropractors, all these people, and no one's been able to solve these people's problems. And that's when I realized, oh my gosh, it's not just me. It's all of medicine is struggling with these types of diagnoses. And so the only thing I really had to go on, my one belief that I carried into all of this was, something these people are doing is causing their pain. And so that was the thing that I kept following. And so that's when I found Dr. Shirley Sahrmann's information, which was about movement impairment syndromes, which I talk about in this book. And then it caused me to go on further down the road of how these people are creating their pain, not only biomechanically or physiologically, but also mentally and psychologically, which I also address in this book as well.
Wow. Okay. Maybe it would be a good time to explain the difference, like you said, between chronic pain and acute pain. How are those two fundamentally different, and why do they need to be treated any differently?
Yeah. So acute pain. Think about it this way, Casey. If we cut our hand, that tissue heals in 7 to 10 days. If we break a bone, that will heal in 6 to 8 weeks. If we tear a muscle, again, 2 to 3 months for that. All right. So anything beyond that 3 month window, everything within that 3 month window, we suspect that our body will naturally heal that problem because it can. It can heal basically all tissues. So if there's a problem, if there's pain outside of that 3 month window, there must be another obstacle to healing that's preventing that from occurring. And so that's why with acute pain, that's why a lot of physical therapists, like if you have an acute back issue, chances are it's going to heal all by itself without you going to anyone, right? And so because that's the way our body is built. And so most physical therapists or wellness practitioners, if they receive an acute patient, really what they're going to educate them in is not hurting themselves any longer, icing, elevating, compressing, all that kind of stuff, massaging, to let the body have a chance to heal itself. And usually that works. So when you see a chronic problem, all of those solutions have already been tried and they haven't worked usually. And so that's when you really have to start thinking about what else is going on here that this person is not recovering from this pain. So a chronic problem becomes more of a detective story than just the simple approach, the RICE, rest, ice, elevation, and compression that we use with acute problems. So that's what led me down this road of as I looked into it more and more, I realized that to understand, to solve complicated chronic problems, I had to have a full body knowledge about how everything from the head to the toe is affecting that particular area of the body, because it's not about that area of the body. That is the vulnerable point in the body, but everything else is contributing to that vulnerability. And that's what I have been figuring out for these past 20 plus years.
Yeah, interesting. With chronic pain, is 100% of chronic pain able to be addressed, improved, maybe go as far as like fixed? Or are there some issues that you just can't really completely sort out? Or is pretty much anything you can definitely make progress on?
Well, it's a good question. I can't, of course, say that 100% can always be fixed through biomechanical methods. However, let's say that you have a disc herniation or something like that, and you're thinking about having surgery, but you haven't really pursued, more systemic thinking approaches to solving your pain. And so what happens is the way that you are using your body is adding stress to the tissue that, for instance, in this case, the disc herniation, which is causing it to hurt more. So if you don't remove those forces acting on that area that's damaged, you can't expect that area to stop hurting. So that will not resolve on its own. Now, there are some cases where, and I'm not anti-surgery, where even though you fix all of those biomechanical forces, you still need surgery. Because what has happened is these changes have been working on your body for so long, we can't overcome the structural deficits that have occurred. A herniated disc, spinal stenosis, spondylolisthesis, facet joint, stenosis, arthropathy. Sometimes those structural problems become so profound that we can't overcome that with biomechanical corrections. However, if you have those surgeries to fix those things, but you haven't fixed the biomechanical corrections that have led to those changes in your spine in the first place, you can expect something else to occur in its place after the surgery has happened. It may be a week, a month, a year, or a decade later, but if you haven't improved the hammers that are working on that spine, then you can expect that spine to be continually hammered even after the surgery. Surgery can only do so much.
Yeah, interesting. So I'm thinking like very similar to like a bariatric surgery. Like, yes, we can cut your stomach and make it a lot smaller. If you don't somewhere down the line change your eating habits, over time, you're going to be right back in the same spot and maybe in a worse place because of the original surgery. You still had to change things. Is that a similar kind of analogy?
Correct. Yeah, very, very similar. Yes.
Okay, gotcha. Okay, interesting. So let's dive into the book, Pain Patterns. Tell us why you decided to write this. Again, you kind of said this is for lay people, but also medical professionals. You've written several books. I want to say 9, 8, 9.
This is number 9. Good.
This
good
is
call.
number 9.
Yeah.
That's a lot of books. So, and each one has a different flavor.
Yes.
Your book before was a little bit more practical and didn't really go into a ton of like explaining everything. Just like shoulder pain, do these things. Back pain, do these things. That was a really cool style. So again, why did you decide to write this book in this style?
Well, what I really, because there was a hole out there in the literature about these deeper problems that are feeding all people's pain. So I see, I have people writing into me with questions about their pain, their histories, all this kind of stuff. I see telehealth people. I see people who have just been through the ringer with everything. And even in my own clinic, I got to see what these people were missing. And so I created these home programs, to fill in those holes. But there was a fundamental understanding of how the body is organized, which is causing pain, that I didn't address in my home programs. And this is basically solving that hole. So basically the way it works is that we have 3 areas of problems in our body that feed chronic pain. One is how we move. Another is how we're built from a fascia standpoint, and fascia is connective tissue. And the third are neurological reflexes that we have that involve patterns of movement. And what I show in the book is that all 3 of these areas, Dr. Shirley Sahrmann identified 3 movement impairment syndromes that cause almost all chronic pain based on how we move. Thomas Myers wrote a book, Anatomy Trains, which identified fascial superhighways running through our body, which closely coincided to Dr. Shirley Sahrmann's 3 movement patterns. And then Dr. Thomas Hanna of Hanna Somatics studied neurological reflex patterns and developed a technique to reduce tension patterns in the body. Well, these reflex patterns were identical to the fascial patterns and the movement patterns. But no one is putting this information together. They're all in their own silos, right? And in medicine, we're really good at staying in our own little silos. But what drove me was my patients' results. What I had to develop a system that solved all pain, that explained all pain in all patients, not just 80% of my patients, not 90% of my patients, all of them. And so by putting all this information together, that's when I started understanding all pain in all of my patients. And the only pain that we weren't able to solve typically was with people who had larger structural problems that had developed because of these dysfunctional patterns of movement and function.
Gotcha. So is that the best way to kind of break it down and think about it, is to put it into those 3 kind of silos and talk about movement, and then talk about fascia, and then talk about the neural reflexes you mentioned?
Yes.
Yeah.
But we can talk about those separately, but our body doesn't work as a neural reflex only. It doesn't work as fascia only. It doesn't work as movement and muscles only. All 3 of these systems blend together to create who we are and how we go about our day. And so this is the information that hasn't been put together in the medical community yet. And this is what I'm hoping. I realize that, I'm not a researcher and I'm not an intellectual, so I'm sure that in my book, there are a medical researcher say, oh, they didn't talk about this. They didn't mention this. They needed more research to support this comment, all this kind of stuff. That's not what my book was written for. It's really, I hope it is an introduction to medical professionals who are looking for other answers to solve pain, to understand what it is that they're missing and where to begin solving those problems in their patients. And from the lay person with chronic pain, even if you don't understand the first section at all, I give you the exercises and tests to understand how these things are playing out in your body. And so you can start solving the deeper problems that are causing these chronic pain patterns that have developed in you.
Got it. Okay, so what are some examples, I guess, of typical things that you see as far as chronic pain, and how somebody could take all three of those buckets and try to suss out what they need to be doing, where the problem is primarily coming from, and what's going to help them take the most steps out of pain?
Sure. So let me show you kind of what I'm talking about. So Dr. Shirley Sahrmann identified an extension problem as one of the primary sources of back pain. Extension problems just mean a spine that is arched, okay? And so this is, so people, for instance, when they go about their day and they're bending over to lift something off the floor, they keep their spine arched. And so they arch their spine coming up and they keep their spine arched going down, where that spine becomes locked in this position, and it becomes painful because it's isolating a particular segment of vertebra in the spine, which then breaks down. It's usually L5S1, which is the vertebral segment that is where our pelvis ends and our lumbar spine begins. So that's a movement kind of habit. If we stand up and lock our knees and we're standing up tall all the time and feel like we have to be military erect, which is what we're taught in school, right? Shoulders back, chest out kind of thing. Well, that's an arched spine. That's an extension problem pattern of movement you've adopted. So Thomas Myers took this a step further with his fascia, and he realized that there's a highway of fascia that leads from the very top of the head along the entire spine and down the backs of the legs to the bottoms of the feet. And he calls that the superficial back line. Well, if you contract that pattern of fascia, that will cause the spine to arch more. So that's why the fascia has a lot to do with the movement pattern. Is if the line of fascia is tight, then you're predisposed to keeping your back arched in the first place, even without any of those messages that say arch your spine more when you bend down and pick something up. And then when, for instance, in the womb, when we start crawling as babies, we tap into something called a Landau reflex pattern. And the Landau reflex pattern allows us to lift our head when we start crawling. What lifts our head is the arching of our spine. And then as we grow older, if we're, for instance, in a dark, dangerous woods and we hear a twig snap and we become more alert to see what's going on, that is you tapping into that Landau reflex pattern, because you're not thinking about becoming more alert. It just happens, right? And that's a reflex pattern that involves the exact same musculature as Thomas Myers' superficial back line and Dr. Shirley Sahrmann's extension problem line. So that's one example of one of the pain patterns, and what I'm talking about when I'm talking about the blending of reflex patterns, fascia, and movement. Now, to test whether you have this problem as a source of your pain, it's really easy. It's a 60-second test. And if you have back pain or sciatic pain, you can do this test right now as you're listening. So all we're going to do, and I think I went over this test maybe last time we talked, you lie on the floor with your legs straight. A floor is better than a bed because a firmer surface will give you more input into your body. So you're lying there with your legs straight for 30 seconds, and you just feel how your back feels. Most of you with chronic back pain will already know you do not want to be in this position, right? So after 30 seconds, I'm going to ask you to bend your knees and put your feet flat on the floor. Does your back feel better in this position than when your legs were straight? 99% of the people out there will say yes. And a smaller percentage will say, I don't feel any difference. My back is still killing me. For those people, bring your knees up to your chest and hug them with your hands. And this should feel really good for your spine, for most of you, all right? So what are we doing here? What have we learned? We've learned that when the legs are straight, my back feels worse. And when my legs are bent, my back feels better. But why would that be? Well, if you're staying on the floor right now, you can feel why that is. It's because when your knees bend, your back becomes flatter to the floor. The arch becomes less pronounced. Simply put, it's that simple, all right? And when you bring your knees to your chest, that flattens the spine even more, right? So this means that you have more back pain with your back arched than with your knees bent, which is a test for an extension problem. It means you have an extension problem. Now, an extension problem doesn't mean that this is solely a movement problem for you, or solely a fascial problem, or solely a reflex pattern problem. It could be a blend of all three, but it's telling you the basic pattern that's causing your pain. And then in my book, I talk about the reasons. We do a lot of testing so you can figure out, why is this pattern happening in me?
That is amazingly explained. I really love that. What would be some of the causes in particular of lower back pain? I remember learning from the book Back Mechanic by Dr. Stu McGill that basically, like, you almost want to be taking notes of the things that make your back be in pain. And this sounds overly obvious, but do those things less. Like, for example, like my dad was experiencing back pain a few years ago, and he learned that pretty much anything where he was like bending forward, like if he was picking up a golf ball or pushing a lawnmower or a shopping cart, that would cause him pain. And so he just kind of restructured the way he moved and changed the way he picked a ball up off the ground. And that helped get him out of pain in that instance. Is that a similar fix to what you're recommending?
It's very similar. However, with an extension problem, and here's where you have to become more precise with understanding your movements. You can pick up a golf ball and come back up, and you're just like, oh man, that killed my back. But was it bending down to pick up the golf ball, or was it coming back up from picking up the golf ball? Most people with extension problems, when they're bending down to pick up the golf ball and their back gets to flex, it feels wonderful. These people enjoy, their back pain decreases when they sit, or if they, they want to sit in a lazy boy all the time, because that puts their back in this flexed position with their knees up higher than their hips. That type of stuff, that's a hallmark of extension problems. And if you're bending down to pick up a golf ball, if you bend down like this and your back is arched and you come up, most people with extension problems, like I was trying to describe with Dr. Shirley Sarman's information, is that they will come up by lifting their head, which arches the spine, and then they arch the spine to come up, rather than flexing the spine to come up. And so it's not only just how you're doing, it's not just that you're doing something, it's really how you're doing something. And that's where we get into some of that detail in the book, so you understand exactly what I'm talking about. So a really easy one is, if you just tested yourself and you said, oh yeah, I have an extension problem for sure, then go ahead, try this one out. Stand up, and now just stand here listen to the podcast for the next 30 seconds or a minute, and feel how your back feels in this position. Okay, now I want you to, without changing anything, I want you to look down at your knees. Most of you are now locking your knees when you're standing, either one or both of your knees. We do this because it uses less of our energy to stand, right? Now we stand on joints rather than using our muscles. Now, go ahead and unlock your knees and feel what happened in your low back. And if you're not sure, lock the knees one more time, and you'll notice that when your knees are locked, your back arches more. So that's a really simple behavior that is contributing to chronic low back pain, is simply locking the knees, which is taking the spine into its extension problem. Most people not only stand with locked knees, but they walk with locked knees as well.
I remember you mentioned that last time. So is the fix for most people to kind of eliminate those patterns that they notice that are causing them pain, or is there work that needs to be done to correct things? So for example, like the first personal training certification that I got talked so much about how muscles get strong, they get short, they get tight, they compress. And so some muscles are too short and other muscles are too long and elongating, like the antagonist muscles. Like, for example, if I'm doing tons of chest press, my chest is getting strong, so it's getting short, and then my shoulders are coming forward and getting that upper cross kind of syndrome. And to allow that to happen, my back muscles are getting really long and stretched out. And so that would recommend that I do a lot more rows, pulling something towards me to work the back, versus doing more chest presses, which would exacerbate the problem. Do you look at it that way as well, or is that kind of a kind of more superficial way to think about it?
I mean, it's superficial, but it works. It works with this approach as well. Because really, let's go back to the extension problem. I'm holding up my skeleton and we have a spine that's too arched. Usually when the spine is too arched, the pelvis is tilted forward too much. What muscle group could possibly cause the pelvis to be tilted forward too much?
I mean, I would think the front of the hips, right?
Yeah, the thigh muscles in the front, right? They attach to the front of the pelvis. So if the thigh muscles are tight in the front, they will cause the pelvis to tilt forward, which then arches the spine excessively. Even if the pelvis isn't tilted forward, the force of the thigh muscles, if they're tight, trying to pull the pelvis forward, still causes an extension stress phenomenon. It would be like if I asked you to lean up against your house and push as hard as you can. That house is not going to move, but that doesn't mean you're not exerting force into that house. And you can feel it in your own body that that force is being delivered, right? So even if your spine shape doesn't move or your pelvic shape doesn't move, the existence of muscles like the front of your thighs, if they're tense or tight, that delivers the same type of extension force to the spine as if this pelvis had actually tilted forward. Does that make sense?
Yeah, that does make sense. So in that situation, would it be beneficial to what most people would think to do would be like classic kind of static stretching, the kind of stretching that we all did before a football game when we were little kids that turned out to be probably not so beneficial? How would we introduce more kind of length into that area if we identified that as being a problem area or being a little bit too tight and contributing to that forward, tilt of the hips?
Yeah, so first of all, you have to identify whether that is a problem in you. So I have that test in the book. And then the way that you test it is the same way that you fix it. Because if the test is going to isolate the quad muscles to see whether they are tight, then why not just use the same test to fix it, right? So I think what you might be referring to, Casey, is that kneeling stretch when you have one leg behind you and one leg forward in that lunge position.
Yeah.
That isn't going to work. And it doesn't work in this case because guess what? The leg that's back, what's happening to the pelvis? It's arching, right? The pelvis is tilted forward in that case. And especially if the quads are tight, it's going to tilt the pelvis forward even more than it would have, right? Which is going to cause a unilateral extension on that side of the spine. Does that make sense?
Yeah.
So you can have thigh muscles that are asymmetrically tight as well. And so that can contribute to one part of your pelvis being forward more than the other, which then introduces shear across the SI joints, causing SI joint pain. It also ends up causing unilateral sciatic pain and unilateral back pain.
Interesting. Okay.
So it matters. So this is a great question, Casey. I'm so glad you brought it up because most people think, oh, I've got a quad stretch. I'm just going to start stretching my quads. No, that's not the answer. First, you have to identify whether it's tight, and then you have to do the correct stretch to fix it because your stretch may be perpetuating and giving into the exact problem you're trying to fix. I run into this all the time, especially with athletes.
Oh, I'm sure. And trying to undo all the education that they'd gotten about how beneficial stretching is. People just like stretch and they think that any stretch that they do, however they do it, is going to be beneficial. And that's definitely not the case, right?
Absolutely. In fact, in the case of hypermobile people, you can overstretch, right? Why would you stretch a hypermobile person?
You'd want to strengthen them, right? You want them doing something to produce.
Exactly. Yeah, exactly. So you got to be careful. And then how do you know if what you're stretching is actually tight? What if it's a tension pattern you're stretching instead of a muscle shortness problem? So a tension pattern is due to more fascial tightness that is due to fascial contraction and muscular contraction rather than tightness. So if a muscle is contracted, stretching it may temporarily stretch it, but it'll come right back to its contraction because the brain is teaching this muscle and fascia pattern to contract. So no matter what amount of stretching you're doing, it's not going to solve that problem because you haven't addressed it at the source of why it's contracted in the first place.
Yeah. Okay. Well, I told you last time, my wife works with fascial releases with people. It's kind of an esoteric form of kind of working with people where she helps pin tissue similar to Rolfing, where a person would be moving through like a range of motion. It's called Rossiter. And she's done courses with Tom Myers, live dissection courses, which sound absolutely amazing. I'm not going to sign up for those anytime soon, but it is interesting to think about the fashion, those lines that we talk about throughout the body, where yes, you might have pain expressing in your right shoulder, but that might not be where the cause is. And wife will always say there's there's the victims and there's the criminals, and don't blame the victims for what the criminals are doing and where the pain can originate. And you're right, without doing the proper testing, without assessing and really going through some of these things to figure out where this is coming from, you won't really understand how to fix the issue. You have to be able to go deeper there. And with fascia tissue, it seems to me like there's obviously like different types of fascia, but it's I try to explain it like the white of an orange, right? Like it's kind of the fibrous stuff that holds things together. And by creating space in a left hip, you might open up more space and relieve pain in the right shoulder. Is that also kind of how you think about fascia tissue?
Well, that's some types of fascia. And then we have something called like the thoracolumbar fascia, which is more like a sheet of fascia, kind of like the plantar fascia on the bottom of our foot, or the IT band running down the side of our leg, which are like a tablecloth of fascia, right? And so, getting into fascia, so there's a certain type of fascia that actually contracts like muscle, and it's called myofibroblasts. Myo means muscle, and fibroblasts are the units of fascia. So this is a particular special kind of fascia that contracts. Well, where myofibroblasts are laid down in mechanically stressed areas of the body. Where the pelvis and lumbar spine meet is an automatic mechanical stressed area of the body, because there are changes in curvature occurring in this area, as well as a large pelvis against small little vertebrae. So whenever the large pelvis moves, it's throwing those vertebrae around wherever, causing stress to those vertebrae. And so there's automatically going to be thoracolumbar fascia filled with mitochondria. I'm sorry, not mitochondria, myofibroblasts in that region. So this is the interesting thing. Myofibroblasts have up to 6 times the contractile capacity of regular fascia.
Wow.
The reason myofibroblasts contract is not because of neural input from your nerves. It's because of a hormone-like molecule called a cytokine that circulates through our bloodstream. That cytokine is called transforming growth factor beta 1. That cytokine is released in times of stress. All right. So the more stress or emotional trauma that you have experienced or have ongoing, let's say you have PTSD, you're experiencing ongoing stress, you're ongoingly activating the myofibroblasts in the areas of your body that have already exhibited mechanical vulnerabilities and have laid down these myofibroblasts in these areas of mechanical stress. What's really interesting, I think, is that for instance, if our biceps muscle is contracting, our brain is saying, bend that elbow, and the biceps muscle contracts. And then when our brain says, oh, okay, you can stop now, the muscle stops contracting. Not so with myofibroblasts, because it doesn't receive neural input. So these contractions of these areas of your body that are under mechanical strain with more myofibroblast concentration undergo a prolonged contraction as opposed to muscular contraction. Now, granted, the myofibroblast contraction isn't as powerful. Like a myofibroblast contraction won't bend your elbow. That's only muscles can do that. But they have this underlying tension pattern of the muscles deeper, say in the low back region, that remain on for longer and longer periods of time. As long as you are stressed, vulnerable, anxious, PTSD, whatever, those muscles will continue to receive the cytokines that continue the myofibroblast contraction. And so the myofibroblast contractions last much longer and kind of have a longer tail of stopping their contraction and a longer head of developing their contraction based on these cytokine release in your bloodstream. I explain this in the book as well.
Yeah. Wow. Absolutely, pun intended. That was fascinating. Great explanation. I really enjoyed that. I just curious, since we're kind of talking about the mental and also like emotional stresses and how that can impact our physical body, how many times have you helped somebody through chronic pain and have them experience some type of like emotional release while you're like working with them?
It has happened several times. I wouldn't say it happens all the time, but it happens a lot. I wouldn't say a lot in my experience. I would think in someone like massage therapy who deals with fascia, they would get a lot more, because I'm not centered on directly affecting fascia with my hands. That's when you usually get those kinds of releases, right? I'm correcting the reasons the fascia has laid down more myofibroblasts in the first place, so that the body will change that distribution because the body is moving better, which disperses all of that stuff.
Yeah, gotcha. Okay. Yeah, that makes sense. Yeah, one thing I do know that you also write in the book is a concept that I'm maybe not as familiar with. I believe it's called functional linking. Can you explain what that is, what that concept is, and how you write about it in the book?
Yeah. Oh, wow. How did you know I wrote that in this book?
I did some digging. I couldn't
It
find the
hasn't
book,
been
but
released yet, for crying out loud. All right. So functional linking is this idea, and this is the whole gist of the second section of the book, is that we need to find the parts of your body that are functionally connected to your pain. So if you have back pain or sciatic pain or SI joint pain or any pain for that matter, my book takes you through what I have found to be the primary problems that most people are overlooking, that they think are not feeding other areas of their body. And so the functional linkings, let's go back. Let's talk about, okay, so we already talked about arching the spine as an extension problem. And we talked about knee locking as a behavior that causes the spine to arch. But what if the knee is locking because of a tight calf muscle, right? So the tighter your calf and soleus muscles are, the more that knee will then lock. And if it's asymmetrically tight, then one knee is locking more than the other, which sets up that rotational torque through your pelvis and spine again that I was talking about, right? So the tight calf muscle, what happens when we walk is that our knee needs to pass over our ankle when we're walking. When that doesn't happen, that force of walking forward has to go somewhere, right? And if the ankle isn't bending to absorb that, then what we've created then is a mechanical force that's being delivered directly to the plantar muscles in the bottom of our foot, irritating potentially plantar fascia, all right? So let's say plantar fascia begins to develop and you have a sore foot. Well, one of two things is going to happen. You're either going to start, and let's say it's your right foot. So either you're going to start loading up your left side of your body more to get off of that right foot, or you're going to start limping on that right foot and not unload that right foot more. So if you stay on that right foot, you'll probably develop is what is one of the reflex patterns I discussed in the book called a cross-extensor reflex pattern, which is simply if you step on a nail and you say, ow, and you take your foot off of that, that is a reflex pattern, all right? So just as quickly as we need to withdraw that foot from the nail, our other leg needs to hold us up. So our other leg is involved with that whole reflex pattern of work, right? Or else we'd fall down every time we stepped on a sharp object, right? So this is one of the big reflex patterns that, again, people in medicine aren't really paying attention to. So let's say you have plantar fascia, and so that hurts. And so what you're doing is you're withdrawing that foot off of that plantar fascia, which lifts that pelvis. The muscles that lift that pelvis off to help that foot get off that sore area are also attached to a rib cage. So that also pulls that rib cage down as well as lifts the pelvis, which causes compression on that side of the spine, leading to what I call a side bending problem, sciatic pain, unilateral back pain, SI joint pain, because once again, you've created an asymmetrical torque through the body. So a tight calf now causing foot pain is now being played out up in the pelvis and rib cage because of our desire to get off of that pain. If we're just going to man up and not unload that foot or not limp on that foot, then we're going to start subtly overloading the left side. Well, then the left side starts breaking down too, or instead of the right side. And so this is what I found in about 70 or 80% of the cases, chronic one-sided back pain or sciatic pain is happening. The problem is on that same side. But in 20 or 30% of the cases, it's on the opposite side that they've been unloading to get off of that problem. And in my book, I teach you how to figure that out too. A simple little test. So this is how functional linking occurs is now you have this problem in your calf that's causing a problem in your foot that's now playing up in your pelvis. Let's say it causes sciatic pain. So you get numbness or tingling going down your leg and your leg becomes weaker as a result of that. And so now it's created this cycle of problems. Foot pain causing pelvic issues that then causes sciatic pain, which feeds back down to the same foot. In medicine, what we would do is address the sciatic pain at its roots in the back or the pelvis. But the true root of that problem is actually the tight calf or the foot issue that's causing that pattern in the first place.
Yeah, well explained. I really like that. I like how the book is aimed, again, at the layperson, but also the medical community. Again, I don't want to talk too much smack about doctors. I think they're all very well intended. I think the system is not the best and is not really set up to really help people with chronic pain, as you well know. I'm just curious, like, how have some of these ideas been received, generally speaking, by people in the medical community? Have they been, by and large, like open to this information, or has it been kind of tough to crack into the medical world and get, your general practitioner doctor to kind of learn about some of this stuff? Has that been a challenge?
Oh my gosh, it's the biggest challenge in the world. And here's the thing. I'll tell you, the people who are even more resistant to this information are physical therapists.
Interesting.
Unbelievably.
Really?
I just tried to write a blog article for our professional journal, JOSPT, Journal of Orthopedic and Sports Physical Therapy. I tried to write a blog article. They rejected it because my information is running counter to where physical therapy has decided to go, which is cognitive behavioral training, right? So it's very difficult for me to accept that, because this is the truth of how the body is working and how we are having pain. And I feel like our profession is passing us by, yeah, I don't know where the cognitive behavioral therapy idea came from, but I feel it's very sad. So I've reached out recently to a whole bunch of doctors, and I've got one medical doctor and I've got one PhD who are willing to even look at my book to review it. So they haven't gotten back to me, but I think it's going to be too much because it's too broad for people to absorb in the medical community. It's too, no doctor has or physical therapist has ever considered neurological reflex patterns, and maybe some have thought about fascia, but no one's ever linked that to movement behaviors, right? So it's just too much for, I think, people to absorb. And that's why the main thrust of this book is written for people with pain. And which is all of my books' focus is for people with pain. I didn't become a physical therapist to change my physical therapy profession, right? I became a physical therapist to help people. What the profession does is up to them. Those are people in academics, research, let them do whatever they want to do. I know it's helping people consistently, and this is the information.
Yeah, interesting. I think it would be maybe helpful if you had an open-minded doctor, if the layperson experiencing the chronic pain bought the book, found the solution, and then presented some of the ideas from the book to the doctor. And again, if you got really lucky and had an open-minded doctor, maybe they would help take some of this on. Our podcast deals quite a bit with nutrition, obviously. And one of the things I hear a lot of people lamenting is that doctors, when they get training for, to become a doctor, they get a very, very limited amount of nutrition education. And a lot of people are clamoring for doctors to get more nutrition education. I kind of push back against that and say, like, no, actually, I'll bet you if we gave doctors more nutrition information, they would probably get the wrong information, but be more certain that they were right about it. And so I think about that same kind of thing about physical therapists. If they're getting, maybe some good information, but this is the way to do it, and there's no other ways to do it, they might be so overeducated in those methods that they're not open to understanding other things, where somebody that has less of an understanding might be able to take it on. It's kind of that dangerous point when you learn a little about something, when you think you know a ton about it, and then you learn more. And the saying goes, like, the further away from the beach you are, the deeper the water gets, kind of a thing. Yeah. You realize you know less and less and less than you did. But I wonder if that's kind of the factor there.
Well, the thing is, I don't ask people to throw away whatever they've learned is working for them on some level, but this is a more comprehensive understanding of the body. And so this will fill the holes and hopefully create a skeletal system from which they can then do what they are good at in the way that they practice. But they can look at it as, oh, what I'm doing is affecting this pattern this is why that's working. And then if this is working for that pattern, maybe I should also look at this thing too then, you know? So I'm not looking to change how people are practicing. I'm looking to expand it, actually.
Yeah.
And so,
Well said.
yeah, and the doctor who I got to review my book is Sean Mackey out of Stanford University, and he's pretty high up there, and so I'm really keep my fingers crossed that he looks favorably on it. But to your point about your idea of someone taking the book to him, I also sent it to one of his receptionists, and
nice.
so she has chronic back pain. Now, Dr. Mackey heads the pain clinic at Stanford University. So you would think that she would have the latest information about fixing pain, but she's still wrestling with back pain. So I'm hoping by sending it to her, she can try the book and then go to him and say, this stuff really works.
I love it. Good strategy. That's a really good strategy.
Who knows?
You can only answer this question generally. I'm just wondering, in your own experience, we hear this from time to time on the nutrition side of things. Like a pharmacist just came on the show about a month ago and said that like she literally got yelled at because she helped one of her people that she was working on deprescribe medication. The main general doctor gave her an earful about it, and she stopped her and said, well, why are you so mad? And she's like, well, now this woman isn't seeing me anymore. Is part of the issue with physical therapists and the barrier there maybe that you're like taking away potential customers if people get fixed of chronic back pain? Has that been your experience at all?
I would not think so, because all of the people I typically see have already been to all of those people. And so, and their doctors are just like, hey, try this guy, see if he can help. They're just like dumbfounded as to what's going on. So I don't feel like I'm competing with them and all. And I think doctors get a bad shake because, they've got so much to do. Physical therapists are supposed to be the musculoskeletal experts. Doctors only get a month or two of musculoskeletal training in med school. How can we expect them to know everything? We get 2.5 years, for crying out loud. Yeah. We should know all of this kind of stuff. So we can't expect doctors to know that stuff. And so I think they get a bad shake a lot of times because they're doing their best. So are physical therapists and chiropractors. But, I think the key is, and this is why I've been able to figure all of this out, is because I haven't subscribed to a particular point of view, because nothing satisfied the ultimate test that my information has to solve every problem that comes into my clinic. And that was the standard that I held for myself. And until I figured that out, I wasn't done. And so now I feel I'm pretty much done. Yeah, there's maybe 5% out there, but for the most part, I can solve just about anything using this information. That's awesome. Why not put it in a book and in digital home programs so people don't have to come see me? That's not fair. So let's just get it out there and maybe change. And maybe the people can then take it to their medical people and say, wow, this really helped me.
Yeah, that's great. I love that. I did have one kind of last question about the group of people that luckily so far in their life, they have not experienced chronic pain. I'm very fortunate. I'm about to turn 41. I just got off the ice playing ice hockey. I go mountain bike. I road bike. I do all the activities that I love to do, and I don't experience any chronic pain. I never really have, besides a few injuries here or there. For the group of people that are listening to this and thinking like, gee, like I don't have any of this. I sure would not like to have any. I'd like to avoid the whole rigmarole. What are some things you recommend for somebody that, is not experiencing any pain to remain that way for as long as possible in their life? Are there certain habits or tactics or things that they can be doing, things that you like, different activities, whatever? I know last time we talked briefly about diet, but what things would you recommend for somebody to maintain a life free of pain if they're not experiencing chronic pain at the moment?
Okay, so this is a great question. Now, I bring up a piece of research in my book that shows that 37% of 20-year-olds have herniated discs that have no pain at all.
Wow.
However, 80% of 90-year-olds with herniated discs have no pain at all. So,
interesting. Having
pain is not a good indicator that something is wrong with your body. All right. So this is why people have developed chronic pain in the first place. is because our brains have become so good at compensating around problems to get off of that area, because our focus, we live in a goal-oriented society. Our focus is to get from A to B. I'm going to get on the ice. I'm going to score 3 goals, And so I don't care how I do it. That's what I'm going to do. And so your brain is going to help you get there. But the brain is not so good at understanding the long-term manifestation or consequences of the compensation patterns it's developed in order to get you to those short-term goals. So just because you don't have pain now doesn't mean your body's perfect. I see it again and again. People with chronic back pain or sciatic pain come in and they say, "Oh, I've got no previous history of injuries. You want to bet $20? I bet you I'll find a previous problem that you have forgotten." And invariably, they have an old problem that they never realized was contributing to their current pain. So I think we need to get out of this idea that no pain means that I'm perfect, right? And not sound like I'm just trying to sell something. The tests in my book will test your system to see whether you have compensations developing that will lead to chronic pain in the future. That would be, I think, the best way to go about it.
Love it. Yeah, that's a great answer. Oh man, this has been awesome. Just to clarify, 3 goals that's like a yearly quarter. That's like a yearly goal, not like a goal for one outing on the ice for me. So yeah, I'll leave the scoring to other people. That's like a yearly quota. This has been such a really helpful conversation. Like I told you, you're really good at explaining all of this. And I think even though we talked, mostly about like that one specific example of the back extension, I think people get a really good sense of like whatever their pain is, there are so many different ways to address it and different solutions. And if they can understand, again, what you're presenting with the testing and the assessments and then the fixes to get there, I think it's going to be a really helpful resource. So I'm very much looking forward to this book coming out. It should be out by the time this episode releases. So I'll be sure to link that in the notes. Rick, this has been amazing for now. Where can people go to find you and connect with you and your work?
Yeah, well, I'm kind of old fashioned. I just have a website. And I believe I have all of that other stuff too, Twitter and LinkedIn, but I don't pay attention to that. So I just go to my website. And then I've also got a YouTube channel that I put on videos of tests, and I answer people's questions, and I explain things on there to help people figure out their pain. So that would also be a good place to get some more information. And on my website, you can buy any of my books on my website. And I'll have a link once this will be for sale on Amazon. So once that is uploaded to Amazon and everything, I'll put the link on my website for that. And by the way, the book comes with videos of all the tests and exercises too.
Very cool.
Those are also found on my website. So you would come back to my website and input there's a code in the book that you need to put in to watch that stuff. But so I want to make sure that people really understand what's going on. And so this should really solve a lot of old, difficult problems for them.
Excellent. Yeah, that's great, man. We will link that in the notes. We'll be sure to link your website. Let me just tell you, at this time of this recording, we're in the middle of an election cycle and probably won't be out of it for several months anyway, the way these things go. So getting back on social media, I would wait. Don't do it now. If you want to get back on, do it in a few months. I would read this one out. We'll be sure to link the book and we'll be sure to link your website as well. But for now, always such great conversation with you. I'd love to have you on to help educate us about movement and staying out of pain. This is going to be really helpful information. I think the book's going to be wonderful. And I'm really glad that you said at the beginning of this conversation off air that it's something that you're very, very proud of. You really should be. So thank you so very much for appearing on our show again and presenting all this wonderful information. We really appreciate you.
Thank you so much, Casey, for giving me a place to voice it.
Absolutely. Anytime. And this has been another episode of Boundless Body Radio.